Nikhil Ramlal is an actuarial consultant at Insight, working in the Insight Health Solutions team, 5th year with the Insight and in the industry. He says he's always been very keen in healthcare and is very excited to be in this space. He has a passion for traveling, exploring the world, and trying many different foods. He says, as he can, as foods as he can. He says he's always up for an adventure. Once again, happily married for 6 months. He says he loves lifting heavy weights, not heavy weights. And he says he loves watching diving. I mean, he loves watching soccer. So he's told me that he is a United's fan, Manchester United. So I just wanted to remind him, it was the 5th of March, 2023 against Liverpool. It was 7-0. Just wanted to remind him on that. And the topic is leveling up our understanding of the patient journey through the health system. Please put your hands together for Nikhil. Louder! Happily married, 6 months! Manchester United fan needs all the love he can get. I'm coming for a slice.
Thanks for the introduction, Siv. I don't know if you saw the picture up there, but I was wearing the exact same thing just so you could all recognize me. Okay. So as funders, providers, consultants, and even advisors, we all have a vested interest in ensuring our patients get effective, good quality care. But of course, healthcare is a limited resource. It's something we need to manage effectively. That's why the role of medical schemes doesn't need to be a passive one of just collecting and dispersing funds, but can intervene proactively for the benefit of members. That's why so much effort, time, and money goes into trying to track and measure quality outcomes, to manage high-cost cases, to look for trends in utilization, and design interventions that can help prevent patients reaching a severe level of disease progression. This is a very important thing that we do, and of course we need to think about how we can level up how we go about it. So our overarching objective is to keep patients healthy, ensure they receive effective care, and to build a sustainable healthcare system. But in order to do that, in order to improve in these endeavors, we need to get a better understanding of how patients interact with the healthcare system. But more specifically, a better understanding of the patient journeys that everyone goes on. It's because we understand that looking at someone's claims at a certain point in time lacks all of the context about what's happened up until then. There's so much more in a patient journey than just what's going on at that time. A lot of that information from the patient journey is also important in trying to manage and coordinate care for an individual. Having a better understanding of the patient journey is what can lead to better quality outcomes, more cost-effective care, and of course, more cost-efficient care as well. So, where do we start? Medical schemes have at their disposal large amounts of data on patients' claims information. With the large amounts of data we have, there's many high-level analysis that we can do to try to unpack what's going on in the claims experience. But it's important to keep in mind that this data was intended for billing purposes. It's meant to see whether a claim should be paid, if it's within a member's benefits, and if they aren't depleted as yet. It's not meant to help unpack the patient journey. Another issue we have with the data is that it's very granular and at a claim line level detail. That means we have to do a lot of work with the data to first get a view at an aggregated level before we can start drilling down to get more detailed insights. Another problem is the data is intractable, meaning we have very large data sets to work with, often requiring some experience in data science before we can even get to any meaningful conclusions. Again, experience in data science isn't something that most clinicians have. The clinicians who are trying to build interventions and manage the burden of disease. Another problem is that the data can be very fragmented, and so a lot more work has to be done in order to work with it or gain any sort of insights from the get-go. So we've highlighted that the data we have, at least in its current form, doesn't really lend itself to being analyzed or to unpack what's going on in the patient journey. But there is one useful thing we can do with it, and as an example, I'm looking at risk adjustment, something that all the actuaries in the room are very familiar with. So risk adjustment is just a method of trying to strip out the impact of the risk profile or differences in the age or gender or chronic status of lives between different areas, so we can get to a better understanding of what's going on. So as an example, we ask the question, if all the members in other provinces had the same risk profile as Gauteng, how would costs benchmark to the province itself? So even after we try to account for age, gender, and chronic status, there's still some significant deviations when we try to benchmark against other provinces. I mean, all things being equal, we would expect patients to have similar healthcare journeys, display similar levels of utilization. But of course, not everything is equal. And from this exercise alone, where we try to account for the risk profile of members, you can see that there's still a level of unexplained variation in the data. So in order to try and level up how we understand the patient journey, we're going to have to go back to our toolbox and see what else can help us. One of the first things we can look at is a diagnosis-related grouper, a DRG. This is just a tool to help us better understand what's going on in a hospital admission. It takes hospital admission data and tries to classify it into different homogeneous groupings. So at a very high level, you could classify it into different classes, for example, surgical, medical, or obstetric. And then we go further and further into more granular categories. At a higher level, we look at major disease categories until we get down to the base DRG and the DRG that attaches some level of complexity to the case. We've seen in industry how these can be used to benchmark costs across different providers, how it can be used as a tool to assess efficiency and then further investigate what's going wrong in specific admissions. But a key problem with it is that it's designed for the in-hospital setting. There's a larger picture of the patient journey that gets missed when we just focus on in-hospital costs. So it's back to the toolbox to see what else we can come up with. One of the next tools I'll talk about is the episode grouper. So at Insight, we do have a similar tool that was designed specifically by clinical experts, not by actuaries, to try and identify episodes of cares for member. So I'm just going to go through a very high-level example of what an episode grouper is trying to do. So on the screen, if you can imagine, each of the dots just represents a different claim for a specific patient. And of course, the line is just representing time. But that patient is going to have many different interactions with different providers, all of which, or some of which, might be related to the same episode of care, some of which might be for different healthcare events. What the episode grouper does is it tries to identify a triggering claim line and then looks further to what claims are associated with the same healthcare event. So there's a lot of logic behind it, but if you can think about the episode grouper looking through all these claim lines and then grouping these together into episodes of care. It also has the functionality to look at overlapping episodes. So for example, chronic beneficiaries will be managing diabetes or hypertension, and they might have a completely unrelated healthcare event in the same period. At least the episode grouper has the capability to sift through that information and separate them into different cases. And the cool thing about the episode grouper is that it can give us different levels of granularity based on what we need. So the description of the episode varies based on what we need it to be used for. So our toolbox now includes something to capture a clearer picture of a patient's journey. But so what? So I just want to touch on a couple of the useful things the episode grouper could do. First off, it can be used as a risk management tool. So we could look at the different types of episodes across different regions, like how we looked at Gauteng and other provinces, and then get a better understanding of the types of episodes that are most prevalent in those areas. We can also try to benchmark it against national averages and see what really stands out there. Once you've been able to identify episodes We can then drill down a bit further to understand what's really contributing to variations in those cases. For example, we could look at the types of providers involved in specific types of episodes. Should they be there? Should they not? And what level of involvement should they have? It could also be used as a useful tool for disease management. So, for example, you'd be able to identify people who have chronic episodes but haven't registered themselves on any of the scheme's disease management programs. Conversely, you could also look at people registered on those programs but don't seem to be reflecting any chronic episodes of care, meaning it's likely not being managed well. For example, we all know that taking your ARVs, managing your HIV can lead to lower downstream costs, better quality outcomes, and improved life expectancy. With a tool like an episode grouper, you'd be able to get a full view of a patient journey, not just what's happening at a point in time. And then you can try to design measures to intervene proactively instead of waiting for the hospital admission. Okay. So while in-hospital costs are, of course, a key concern to funders, there's still other costs before admission and post-discharge that need to be considered. There's also a large amount of episodes that don't involve the hospital setting, but we don't really have the tools to really identify those episodes, group together the claims, and think about how we can structure the care. So the episode grouper presents an opportunity to think about other innovative ways to structure ARMs, more specifically involving providers in the out-of-hospital setting. The episode grouper, I should just emphasize, shouldn't just be used to identify or keep costs low. It should also be used as a tool to identify areas of underservicing, where patients aren't receiving enough care and costs aren't high enough. Often a concern that's raised during benefit design. It could also provide a means to assess the level of PMBs coming through across an entire episode of care, and then decide if that's really appropriate and according to what's intended by regulation. So we've discussed how the, I forgot I had a couple extra slides in here. So this here is just an example of how the episode grouper could classify different types of episodes. Here we're specifically looking at the level of utilization or number of episodes in the population, and you can contrast it across the average cost per episode. And that gives you a way to identify your high cost, low frequency episodes versus your low cost, high frequency episodes. And of course, the way you design interventions to manage those types of diseases will vary. It also gives you the opportunity to track how those move over time, so then you can start to monitor the effectiveness of some of the interventions put in place. Another useful option with the episode group is you can try to identify seasonal trends in types of episodes. So if you have a look at the bottom right hand of the screen where we look at respiratory diseases, you can clearly see that there's a seasonal pattern to it. Sure. So that's just really some rough examples of what it could use for, but you could also take these high-level groupings of episodes and then focus on a specific set of sub-episodes that might be of interest to the scheme. So all of that is about how episodes get identified and categorized, but there's still another useful a useful aspect of the episode grouper. It starts to piece together different types of episodes for a specific patient. That means we get a much more holistic view of the entire patient journey. So based on the past episodes of a member, we'd be able to categorize them or get a better understanding of the risk profile that they fit into. Something that goes a lot more beyond just age, gender, and chronic status. At a point in time, we could see who's really healthy, those suffering from significant chronic conditions, or those expected to have maternity admissions in the next 9 months. So that's all about how we can analyze the past trends, but what about the future? The episode grouper gives us the tool to build a better risk profile of members. It gives us the tool to better unpack what's happened to that member historically, and then piece all those episodes together to get a view of the patient journey. That's a lot of information, and we know that a person's historical medical experience is usually a good indicator of what's going to happen in the future. So let's use it. Sorry, I know there's a buzzword on here and all the actuaries are getting excited. I'm not going to go into all the details of what a GLM model is. Happy to discuss over a glass of whiskey later. But the question we're really trying to ask is, given a member's history of episodes, given what the episode grouper says about their risk profile, can we predict whether or not they'll have an admission in the next year? And our initial approach is to take the statistical tool, a GLM model, and then try to see if the variables we're given, like the episode history and so on, can help predict whether or not they have an admission. And I just want to make the caveat that in a GLM, there's many different combinations of models you can consider. So on the next couple slides, we're just looking at a few of the ones that we did manage to come up with. Before we get onto the results of the modeling, I just want to touch on two very important concepts, and that's one of accuracy and of precision. So accuracy really refers to, out of all of the outputs from the model, all the predictions of whether someone does get admitted or doesn't get admitted, how many of those are correct. But when we start to look at precision, the focus is on all the positive predicted values. So looking at all of the people the model predicts are going to get admitted, how many of those are correct? Now, the distinction between the two might seem silly, but if you think about it, when you're trying to roll out interventions, you would only apply those to those people the model says are going to have an admission. Again, anyone it says aren't going to be admitted, we probably wouldn't do anything. So we can think of that as cost neutral. So on this slide here, I've just got results from a bunch of different models that we tried to fit. The blue bar is just looking at the accuracy of the model, and between all of them, not much difference. But you can see that all of these models have some varying levels of precision. What I really want to show on the slide is that the initial two models, looking at just the demographic information and how those variables interact with each other, gives us not a great view of precision, up to around 45%. But once we start to bring in more stuff from the episode history, the types of episodes, and the risk segmentation of the member, that's the risk profile I was talking about earlier, we start to get more and more precise models. So there's definitely a lot of value in looking at the history of a patient or their patient journey. So that's all well and good. But how can we then take that information and try to tailor some of our interventions? So we try to consider a more specific type of example, looking at cardiac admissions. So on the side of the slide, I've just got a bunch of different sources of information that we relied on. This includes the episode history, the types of episodes, the types of admissions the person has had. We also looked at the usual patient demographics, as well as any recent healthcare interactions with GPs and specialists specifically. Since we are focusing on cardiac admissions, there's a list of medicines that we also tried to focus on here. So drawing on all these sources of information, we then went about a similar exercise of fitting a bunch of GLM models and then trying to see how precise our model could become. So here I've just tried to do a comparison of the precision between the model we eventually came up with, the black graph there, and our other options at our disposal. So the first one is if I were to take the entire population and guess at random who's going to have an admission, I'd have about a 1% chance of being right. Then let's say I don't take the whole population, but I look at everyone with a chronic condition and try guess again. I have about a 5% chance of being right. Then we try to fit some more generic GLM models and see what those could come up with. And we got to a precision score of around 12 to 14%. But once we started to bring in information from the episode grouper and the patient journey, that becomes a much more precise model. So of course the question you all have, 54%, is that even great? I know if I got 54% on a test, I wouldn't be here today. That's because my mom would have killed me. But just bear with me, and let me just take us through two examples that might better explain how useful that actually is. So I'm going to do what actuaries do best. I'm going to make a bunch of assumptions here. So let's say the average cost of a cardiac admission is about 50,000 Rand. We're going to apply some managed care intervention that can reduce the chance of admission by 20%, and we say that these interventions cost about 1,000 Rand per patient. Out of my 1,000 high-risk beneficiaries, using the model with 14% precision will give me about 140 of those admissions that would have happened in the absence of managed care interventions. If we then roll out those interventions, the 20% reduction in the admission rate means we avoid 28 admissions, and that means through a lower level of admissions, 1.4 million is saved. Their interventions cost 1,000 Rand per patient, so that's a cost of 1 million Rand. Some quick maths, and then the net effect is just a saving of 400,000 Rand, and you're able to intervene with 28 beneficiaries. So you've gotten better quality outcomes for 28 lives. That's using the weaker model. Now, if I take the same scenario, apply all the same assumptions, but instead I'm using my much stronger model to try and identify these patients, what I'm going to see is that once I roll out the interventions, I'm expected to reduce admissions by 108. That's a saving of 5.4 million, and then of course the cost of the interventions is the same, 1 million Rand. So the net saving we get in this instance is 4.4 million, much higher than before, and we're also able to help 108 beneficiaries instead of the 28 in the previous example. So this is just sort of a case study or illustrative example of how useful that kind of information on the patient journey can be. So we've highlighted that the current data, at least in its raw form, doesn't give us enough information to capture the entire patient journey. The patient journey comprises of numerous interactions with the healthcare system, all of which contribute to what's really going on with the individual. If we don't have that view, we're then faced with very limited avenues to level up our understanding of the patient journey, and that gives us limited options when we're trying to roll out our interventions. But if we're able to apply more powerful tools to the data, like the episode group as an example, it can lead not only to more meaningful analysis of past trends and what's going on, but it might also be able to help inform our initiatives going forward. Thanks.